This documentation module is on the key elements of an evaluation. All of the documentation requirements and guidelines are found in the Medicare Benefit Policy Manual. Manual 100-2 includes more than 20 chapters, and Chapter 15 is the one that describes what is required in outpatient PT, OT, and ST documentation. The chapter, however, is named Covered Medical and Other Health Services. So when you go to find it, look for that one, and then go to Section 220 and 230 where you will find the therapy guidelines. National Government Services is the local Medicare administrative contractor for the state of Illinois. Therefore, you can find more guidance on its website. They have a published local coverage determination for outpatient PT and OT services, which all Part B providers of therapy in Illinois should be aware of. So throughout this module, there is additional guidance included from it. I did not include the web link for NGS because it is too long, so if you just Google search NGS for Illinois, you will be able to find it. The Medicare manuals tell us that in order for therapy to be payable, the services must be covered. The documentation must be legible. Now, you think in an EMR world that is easy, but documentation is not legible when there are abbreviations used that are not defined or not standardized. Documentation is also not legible when words are misspelled. So it's best to remember that most reviewers are not therapists, and therefore they are not familiar with your specialized abbreviations or shorthand abbreviations that you might use. Try to remember to define them, at least in the beginning, or when you use a new one. Lastly, the services must be medically necessary, and we'll focus on that next. Services are generally considered medically necessary when they are skilled rehabilitative services provided by clinicians, that means PTs or OTs, or therapist assistants when appropriate. The services must be approved by a physician or a non-physician practitioner. They must be safe and effective. So number 2, 3, and 4 are pretty easily proven by licensure, by physician signature, and in the absence of patient harm. Number 1 and 5 are what must be proven in all parts of the documentation. The initial evaluation or the plan of care, including an evaluation, should document the necessity for a course of therapy through objective findings and subjective patient self-reporting. Remember that it sets the stage for the remainder of the plan of care. This is the opportunity to explain why the patient is seeking physical therapy and why they are seeking it now. It is also the time to demonstrate that this patient's condition or impairment or injury can only improve if he or she receives a skilled PT or OT service. Documentation of the evaluation should list the conditions and complexities, and where it is not obvious, describe the impact of the conditions and complexities on the prognosis and or the plan for treatment, such that it is clear to the contractor who may review the record that the services planned are appropriate for the individual. Think of it as connecting the dots. You, with your specialized training and education, may understand why a comorbidity of obesity or CHF will complicate the patient's recovery, but perhaps the reviewer doesn't understand how that might impact low back pain. Indicating what you think the patient's prognosis for recovery is very important. In fact, Medicare and NGS both expect this to be a part of the assessment on evaluation and with every progress report. So include what your assessment of prognosis is and why you think it's that. Initial evaluations need to provide objective, measurable documentation of the patient's impairments and how any noted deficits may affect ADLs or IADLs and result in functional limitations. Functional limitations refer to the inability to perform actions, tasks, or activities that constitute usual for the patient. Functional limitations must be meaningful to the patient and/or caregiver and must have the potential for improvement. In addition, the remediation of such limitations must be recognized as medically necessary. Medicare requires an evaluation, and it should include a diagnosis, a description of the specific problem to be treated and/or evaluated. The diagnosis should be specific and relevant to the problem that you're going to be treating. In many cases, a medical diagnosis might be obtained from a physician or non-physician practitioner, and an impairment-based treatment diagnosis that you find. Both are relevant. Also, the results of instrument measurements. For the most part, these are pieces that are included in Rock Valley evaluations. What can be improved upon, however, is what these instruments mean. In other words, what are they measuring? What do the scores mean? This will be discussed more in a later module. Making the case that this patient's condition will not resolve on its own is also important, especially when the plan of care is written for 6, 8, or 12 weeks, as it often is by Rock Valley clinicians. So this can be done through identification of other health services concurrently being provided for the same condition, like for instance, physician services or chiropractic, psychology, dietetic services, or perhaps identification of durable medical equipment that's needed for the condition. You could also identify the number of medications the patient is taking. If there are complicating factors that affect treatment, describe what those are or how they affect it. For example, cardiac dysrhythmias are not a condition for which a therapist would directly treat a patient, but they may directly and significantly affect the pace of your progress. Documentation should indicate how that progress was affected, or if the severity of the patient's condition, as reported on your functional measurement tool, might be so great that you may need more time. Perhaps the patient has, in addition to what you're treating, another disease or condition being treated, or generalized musculoskeletal conditions, or conditions affecting multiple sites, and so these are going to affect the rate of recovery. If the patient has a mental or cognitive disorder, that might also be being treated in addition to what you are treating. Lastly, identify any factors that might impact severity, including the patient's age, the time since the condition came on, the cause of the condition, the stability of the symptoms, perhaps whether or not the patient is experiencing typical symptoms or atypical symptoms, and then the availability of an intervention that you know to be effective. One of the most important parts of supporting medical necessity is showing how a patient's level of function has changed. This may seem like a burden when a patient is recovering from a surgical procedure, but it still is necessary to demonstrate that they are not at their prior level of function. That will help justify the patient's plan of care. Clinical complexity is defined by the difference between a patient's primary level of function and their current level of function. If there is little change or no change, then you need justifying statements for why therapy is required. Maybe it's a quality thing. Is it now preventing them from going to work? You need to describe this in a short paragraph. How much assistance are they needing with specific ADLs? Not just generally they were independent before and now they need assistance, but try to bring it down to the individual activity of daily living. Here's an example from Rock Valley documentation. ADLs were listed, but they could be much more specific. For instance, the comments state that she presents with the assistance of her husband. How much assistance, and for what? The therapist notes that her pain causes difficulty with weight-bearing activities such as walking, standing, and stairs. So stairs, how difficult is that? Does she need assistance with it, or is it just painful? The therapist also notes that she's no longer using the boot and no assistive device, but she's walking with a limp and stairs are very difficult. Standing is very limited. Again, those are very subjective statements. So we need to indicate a little bit more about how limited they are. Does it prevent them from being able to perform a full ADL or complete a shower or cook a full meal? The therapist also notes that the patient was very active with home chores, walking for exercise and shopping, assisting on the farm, traveling, and family activities. So those are good. Listed some chores that she could do before. Are those the same ones that she can't do now? Those are things that we can't just presume. It's always good just to spell it out in the notes. Other means of supporting the medical necessity for an evaluation and therapy plan of care is to describe any prior therapy history for the same diagnosis, illness, or injury. If recent therapy was provided, then you must establish that additional therapy now is reasonable and necessary. If you can, document any information about medical care that was provided prior to your episode, such as perhaps sniff care or home health episodes. Maybe if the patient was treated by another therapy discipline or at another therapy clinic. Quality of life is also very important to patients, so try to include documentation that indicates what their health-related quality of life is. It's as easy as asking them, at the present time, would you say that your health is excellent, very good, fair, or poor? And if the patient is unable to respond, you can simply indicate why. Social support and environment is another piece of the puzzle. Does the patient live alone, with a caregiver, in a residential care facility? Do they require additional persons in the home in order to be safe? Does the home situation have obstacles that they have to overcome, such as stairs without handrails? Do they have usual responsibilities in the home environment? Are they planning to live in the same environment at the conclusion of your outpatient therapy? Who do they live with, and are they able to take care of them or assist them at all hours of the day or just certain times of the day? And again, do they require the therapy to reduce their dependence on someone else? As I mentioned earlier, there must be objective and measurable assessments to demonstrate that there are impairments that PT can address. These might come through functional assessment, summary scores, comparisons to prior assessment scores, maybe from commercially available outcome instruments, such as the Care Connections that Rock Valley uses. They could be other functional assessment scores, such as tests and measures validated in the professional literature, like the Oswestry, the Neck Disability Index, the Lower Extremity Function Scale, or DASH, or any other measurable progress towards identified goals for functioning in the home, such as the level of independence or the amount of assistance needed with specific ADLs. Regardless of the type of functional test or measure you choose, you want to objectively measure and/or describe the patient's current level of functioning. Connect the dots in your assessment of what testing helps you determine as the source or cause of the limitation. Use concise, objective measurements. Try to avoid the min, mod, severe types of description when there are more specific definitions or measures available. For example, when measuring shoulder flexion, active range of motion, document degrees of motion rather than shoulder flexion has minimal loss of motion. Interpret what standardized tests mean. Don't presume that a Care Connection score of 40% is going to be understood by anybody who reads it. Is that good, bad, or okay? What about for this person with their comorbidities and previous level of function? Is that a score that's to be expected? That's what needs to be explained. And then finish it up with the clinician's clinical judgments or subjective impressions that describe the current functional status and a determination that treatment is either needed or not needed. And if treatment is needed, then provide a prognosis for return to pre-morbid condition or for the goals that you've established in your time frame and plan of care. So here is an example. The Care Connection score of the lower extremity was 24 out of 100, but we don't know if that's good or bad. There's nothing in the comments. And another patient. The pain was only 1 and the Care Connection score was 72%. Is it a better score because it's higher, or does it indicate a higher level of disability? One is the lower extremity Care Connections, one is the lumbar Care Connections. The comments really should indicate that. Finally, as a therapist, you want to do a self-check at the end of every evaluation. Check yourself. Does the diagnosis, history, and reason for referral you indicated suggest that this patient needs therapy? Have you explained why? Did you demonstrate a clear change in function? Or did you provide just a generic, non-descriptive, subjective one? Did you connect the dots for the reviewer? Did you explain why all of those things add up to needing 8 weeks or 10 weeks of therapy, and that it requires TheraX, therapeutic activities, manual therapy, or anything else that you include in the plan of care? And that concludes this module.